Now, our next speaker is Dr. Michele Lambert. She's the Medical Director for Special Coagulation Laboratory at the Children's Hospital in Philadelphia, in addition to being the Associate Professor of the Department of Paediatrics at the Perelman School of Medicine at the University of Pennsylvania. She's also an attending physician at the Division of Haematology at the Children's Hospital in Philadelphia and the director of the Paediatric Platelet Disorder Program, which focuses on providing innovative care in the diagnosis and treatment in pediatric ITP and other platelet disorders. Amongst her many titles, she also conducts a lot of research and clinical trials into new and emerging treatment therapies. And we really do welcome her along today. So thank you, Michele. Thank you so much for joining us. So we look forward to Michele's update today. Michele will be talking to us today and presenting today on an update on pediatric ITP, and she'll also be touching a little bit on COVID-19. So without further ado, Michele, I'll let you take over.
Hello, everybody. My name is Michele Lambert, and I am a pediatric hematologist at the Children's Hospital of Philadelphia in the United States. Today, I'm going to talk to you about some updates about pediatric ITP. So my objectives are to briefly summarize what we know about pediatric ITP and talk a little bit about how it's different from adult ITP, to bring up some gaps in our knowledge and why it's so hard for many doctors to care for patients with ITP, to develop a rational approach maybe to activities, sports, and treatment, and to touch a little bit on ITP in the current pandemic and specifics to pediatrics. So, thinking about basics of biology of ITP, we know that ITP is a disease of platelets and a low platelet count. Platelets are created in the bone marrow, and the main driver of the development of platelets is thrombopoietin, which is created by the liver, which is made by the liver. And we have hematopoietic stem cells. These are the baby cells in the bone marrow that grow up into megakaryocytes that eventually release these platelets into the circulation. What happens in ITP, generally in response to a preceding viral infection in pediatric patients, is there's an abnormal antibody response. The immune system gets confused and starts to think that platelets are a virus and starts to remove those platelets with the production of antibodies in the majority of pediatric patients who develop ITP. Those antibody-coated platelets are then removed in the spleen by macrophages. Macrophages are part of the immune system, and they basically just eat up antibody-coated stuff, and that is most commonly bacteria and viruses, but in this particular case, because the immune system is confused, it's eating up the platelets. There is an important part of the immune system called the T helper cell. This T helper cell helps to keep the B cells healthy and the macrophages healthy. And when the T helper cells are involved in this immune response, they make cytokines, which are basically hormones that tell the B cell and the macrophages, keep going, you're doing a great job, and keep doing what you're doing. Those cytokines can also tell another type of T cell, the cytotoxic T cell, to just take the platelets out all by themselves. And sometimes what happens is this immune response can change over from an antibody-directed response to a direct T cell response all alone. And so eventually what might happen is you may not have any antibodies at all. And this explains why some patients will start to respond maybe to antibody-directed treatments, but like IVIG, and then eventually need T-cell directed treatments like steroids or cyclosporin or other treatments like that. What we've learned in recent years is that the antibodies don't just attack the platelets, but they can also attack the megakaryocytes themselves within the bone marrow and stop the bone marrow from being able to even make mature megakaryocytes or release platelets even before they come out of the bone marrow. And we know that these antibodies can also alter the platelets themselves and activate other types of platelet destruction besides what happens in the spleen. And so not everybody will respond to getting their spleen removed or to a splenectomy, and not everybody will respond to that type of treatment. And we know that this immune response to the platelets is quite complicated now, although we used to think that it was very simple. Phew, so let's just take a break for a second and breathe. That's pretty complicated pathophysiology. The good thing about that complicated pathophysiology is there are a lot of different places that we can target in order to try to treat ITP. So there's lots of treatment options that are available and new treatments that are in development. The tough thing about that is that it may take us time to figure out exactly what type of ITP your child has and what part of the immune system is really responsible for your child's ITP and how to best direct treatment in order to get the best response for your child's ITP. Most patients will respond eventually to some type of therapy, but it might take cycling through multiple different treatments to get to that optimal therapy. So how is pediatric ITP different from adult ITP? Well, in pediatric patients, most children will eventually get better. There are very few adults who had ITP as a child, and most often when that happens, it isn't simple ITP. It isn't just ITP with nothing else going on. Significant bleeding is rare in pediatric ITP, although it certainly does happen. But most patients don't have significant bleeding symptoms, and most patients are going to do extremely well with their ITP as long as we can manage all of the other things that can come with an ITP diagnosis. And most patients are otherwise very healthy, which makes having ITP very hard for them because they feel great, they don't have any other problems, and they don't feel sick, and they don't have any other medical complications. This is good because their risk of bleeding is much lower, but it's also bad because they don't like having a disease, and they don't like being reminded that they have a disease, and they don't like being told that they can't do something because they have ITP. So quality of life has a very large impact, and especially overall long-term on well-being of patients with ITP if we don't do something about that. So who should be treated with ITP? Well, certainly anybody who has significant associated bleeding at the time when they're being seen for their ITP. So anybody who has bleeding in the gut, in the GI tract, or urinary tract bleeding that you can see. Anybody who has significant bleeding in their mouth or from their nose, and I don't mean just a little bit of blood when you blow your nose with the sniffles or something like that, but I mean a real nosebleed. Certainly anyone who has bleeding in and around the brain should be treated for their ITP. Also, somebody who has bleeding that's difficult to control, for example, who has heavy menstrual bleeding that is very difficult to control, or prolonged nosebleeds or something like that, should definitely be treated for their ITP. And this bleeding difficulty to control tends to be related to how long the bleeding's been going on. So the sooner a patient presents to the emergency department with their bleeding symptoms, the easier it is to control the bleeding. And it isn't always correlated with the platelet count. So patients can have a platelet count of 60,000 and have significant bleeding, or can have a platelet count of less than 5 or less than 2 and not have any bleeding symptoms. So it really is quite variable. The other important thing to take into account is what's going on with the patient. What is their quality of life like? How are they handling this diagnosis of ITP? What's going on? What else do they want to do with themselves and with their life? And how are they feeling as a result of this diagnosis of ITP? It's not just about what the platelet count is or what their bleeding symptoms are, but how is this ITP diagnosis affecting them? So talking a little bit about bleeding and diagnosis, the majority of pediatric patients, this was a large study encompassing over 850 patients, the majority of pediatric patients have no bleeding, even with very low platelet counts at diagnosis, even with platelet counts of less than 20,000. Most patients had no bleeding or mild bleeding. Only a very small percentage of patients had severe bleeding, and those patients, the majority of patients had very little bleeding. There was only in this group of patients one patient who had an intracranial hemorrhage, and that patient actually did really, really well with that intracranial hemorrhage. But the intracranial hemorrhage is the dreaded bleeding complication of ITP and is the reason that a lot of patients are treated, even in the absence of any other bleeding symptoms. It is the reason that many patients have pretty significant activity restrictions and get lots more CBCs maybe than even is really necessary, and why ITP has such a profound impact on pediatric patients' lives. We did a study and we looked at what physicians think of as high risk or low risk activities. And when we asked physicians to rank different activities as high, moderate, or low risk, you can see here that when we look at different activities, there's really not even great agreement among the different physician responders between what activities are high, moderate, or low risk activities, with even some physicians considering, basketball to be high risk and low risk at the same time. And things like soccer being considered moderate or high risk by the majority of physicians that were surveyed. I think that this demonstrates that we just really don't know. We don't have a lot of good data that tells us where most of these sports activities fall, and that it's also very dependent on the level of participation of the patient and how competitive that particular sport is as well. What we do know is that there's very little data in the literature about this in general. There's only one case report of ITP presenting in a football player. This football player presented with a small, very treatable intracranial hemorrhage in the setting of a new diagnosis of ITP. And so he was not previously known to have it prior to this presentation. And so this is the only report of ITP in a football player and of intracranial hemorrhage in a football player with ITP. There's no other reports. And I think, if there was a lot of intracranial hemorrhage as a result of sports participation, there would be a lot more of this in the literature. And so I do think that, with the caveat that bleeding is the best predictor of additional risk of bleeding, that as long as the patient isn't bleeding, that it is reasonably safe for patients to participate in most activities, and that should really guide our activity restrictions. We should recommend that our patients avoid activities with high risk of concussion or head trauma, and we really need to consider the risk-benefit of their participation in those activities and consider platelet-modifying therapies if the patient really is invested in participating in those activities. For example, if we had a patient who was going to get a college scholarship in order if they played a particular sport, then we should enable that patient to play that sport and even use a platelet modifying therapy in order to allow them to play that sport so they can pursue their dreams and be able to do the things that they want to do. So what about school in general? Things like field trips and class participation in gym class and other things like that, recess and outdoor play, and what about what to tell the school nurses? I think practice varies quite a lot. In general, I do tell patients that gym class is okay, recess is okay. In fact, it's really important that children not be removed from their normal activities in school as much as possible and not really be isolated. Otherwise, again, this ITP diagnosis has a huge impact on their quality of life. I do recommend that children be allowed to continue the activities that they're already doing, as long as they're not having significant baseline bleeding symptoms, and that we have a very detailed discussion of the risk of their various activities that they're already participating, and an individualized discussion of the risk-benefit. But exercise is really critical for health and well-being of patients, and so it's really important that we try to find a way to allow that patient to continue to have some kind of physical activity. Field trips should not be restricted, and patients should be encouraged to participate in safe sports whenever possible. And I do provide letters of support for activity, giving guidance about when to call for particular concerns. So what about severe bleeding? How much of a risk is it, and what do we do when it happens? What do we know about severe bleeding in pediatric ITP? Well, there's currently a big study going on in collaboration with McMaster University between several pediatric and adult centers, looking at emergency bleeding and severe bleeding in patients with ITP. And this study is looking at both pediatric and adult patients. But we do know that outcomes are worse with a delay in presentation. So the sooner that you present with your significant bleeding episode, the better. And this is particularly true with bleeding in the head. And so it's really important that patients be encouraged to talk about what they're doing and to let their parents and their providers know if they hit their head. This is another reason that it's really important to establish that relationship with your physician, and that the child has a relationship with the physician as well, that they know that they can talk to the doctor, that they're not going to get in trouble if they tell you that they were riding their bike, or if they tell you that they were roughhousing with a friend, or that they were climbing a tree or something like that. The more restrictive we are with the activities, the less likely they are to tell us if they have an accident or something like that. So it's really important to establish what is safe and what is not safe, and then have them to tell us if something does happen. Bleeding gets harder to control the longer it lasts, and that's why we talk about letting us know as soon as something happens. Changes in symptoms are really important. If you're a person who never gets headaches and suddenly you're having a headache that's just not going away, that symptom is really important. Even if it's a minor headache, you need to have a CT scan. If you have nausea and it's not getting better, that really needs a CT scan. And when you do have evidence of even a small bleed, it may just need to get the kitchen sink treatment. You need IVIG and steroids and a platelet transfusion and a thrombopoietin mimetic and all of the treatments all at the same time. Bleeding is slow. In ITP, it doesn't happen all of a sudden catastrophically. It tends to happen slowly over time, and that includes bleeding in the head. So many patients who present with the really catastrophic, really horrific bleeding in the brain have been bleeding for days before they presented with that bad bleeding in the brain. And so it's really tragic that those patients have poor outcomes, because almost always they've been bleeding for more than an hour or two. They've often been bleeding for more than a day by the time they actually present with their bleeding. And so it's best to intervene as quickly as possible, but we have time to intervene, but only if we know that we need to do something different. And so it's really, really important to have that good relationship with your provider. And if you don't like the answer that you're getting, just go to the emergency room and insist on a scan. and get that done. So to summarize those sort of basics, most patients with ITP don't have significant bleeding, and the risk of bleeding in the children is quite low. For this reason, our current recommendations from most of the pediatric societies and from the American Society of Hematology is that the majority of pediatric patients can be carefully observed without requiring platelet-raising therapies, and every effort should be made to normalize life as much as possible to minimize the impact of that ITP. For this reason, quality of life is an important consideration for deciding whether or not to treat that patient with ITP, and this is new in the latest guidelines. Reasonable accommodations are necessary in order to mitigate the impact of ITP on health-related quality of life. So changing gears just a little bit and trying to address some of the new impacts of the SARS-CoV-2 pandemic and ITP. There are case reports of ITP associated with SARS-CoV-2, both vaccine and viral infection. And that's not really a surprise given that pediatric ITP is often triggered by viral infection. There's little systematic data in the literature for us to really understand what the true risk is. And there's almost no information about COVID vaccines and pediatric patients and ITP. And that's because the COVID vaccines in the pediatric population are incredibly new. But based on other data, I think we can start to make some reasonable assumptions about what we can expect. Based on the measles vaccine experience, the risk of ITP is higher with a natural measles infection than it is with measles vaccine. And re-exposure to vaccine doesn't pose a higher risk in a non-immune individual than the initial exposure to the vaccine. So it's better to revaccinate or to vaccinate an individual than it is to get the natural measles infection. And so based on that experience, our recommendation has been for children with ITP or with a history of ITP to be vaccinated for SARS-CoV-2. And this has played out somewhat in the adult experience. The risk of new ITP with natural infection is really unknown compared to vaccine, although it may be higher. It's hard to really be sure because it's just not been systematically collected, this data. Re-exposure to vaccine, however, doesn't pose higher risk of ITP relapse in patients who have a history of ITP. We do know that there is some risk of platelet count drop with vaccination in patients who have a history of ITP when they get the COVID vaccine, but there doesn't seem to be a clear correlation with first dose, second dose, booster doses so far, and just because you drop your platelet count with the first dose doesn't necessarily mean you'll drop your platelet count with the second dose, and if you don't drop your platelet count with the first dose, it doesn't completely predict that you won't drop your platelet count with a second dose. And so from that experience, and the majority of patients who have been vaccinated have had good vaccine responses, unless they've recently gotten rituximab or some other therapy that influences their response to vaccine. And the majority of patients who have had a vaccine-induced ITP have responded to regular ITP therapies for most patients. So for most patients, it appears to be better to vaccinate than to get natural infection, and it does appear that it is safe to vaccinate patients with a history of ITP or with current ITP with the COVID vaccine. That has certainly been my personal experience with my patient population who have been vaccinated so far. Most of my patients, actually all of my ITP patients so far, have done just fine with the vaccine, and none of my ITP patients have even required an escalation of therapy. However, we are still collecting the data for the pediatric population. So with that, I will thank you for your time and attention, and I'm happy to participate in our virtual conference and answer any questions.
Thanks, Michelle. That was really wonderful. As Michelle mentioned, feel free to add any questions into the Q&A section of the webinar. Just head in there and we'll try and get some of those questions answered for you during the Q&A session later today.